Acute respiratory distress syndrome, or ARDS, is a life-threatening lung injury. It prevents the lungs from providing enough oxygen to the body. ARDS can be caused by various factors, including infections, trauma, and aspiration. Patients with ARDS often require mechanical ventilation to assist their breathing. This life-saving intervention helps patients breathe when their lungs cannot function properly. Without mechanical ventilation, many ARDS patients would not survive. Mechanical ventilation involves using a machine to move air in and out of the lungs. This machine, called a ventilator, connects to the patient through a tube inserted into the windpipe. The ventilator delivers breaths at a set rate and volume, ensuring the patient receives enough oxygen and eliminates carbon dioxide. While mechanical ventilation is essential for ARDS patients, it is not without risks. Mechanical ventilation can cause further lung injury if not managed carefully. This is called ventilator-induced lung injury, or VILI. VILI can result from the high pressures and volumes of air delivered by the ventilator. These pressures and volumes can overdistend the delicate lung tissues, leading to damage. Therefore, it's crucial to understand the potential dangers of mechanical ventilation and how to minimize them. Mechanical ventilation, while life-saving, can harm the lungs if not carefully managed. The pressures generated during mechanical ventilation differ from the physiological pressures in normal breathing. These unphysiological pressures can damage the delicate structures of the lungs. Two key pressures are important to understand: transpulmonary pressure and pleural pressure. Transpulmonary pressure is the pressure difference between the inside and outside of the lungs. It is the force that inflates the lungs. During mechanical ventilation, if the transpulmonary pressure is too high, it can overdistend the air sacs in the lungs, called alveoli. This overdistension can lead to damage and inflammation. Pleural pressure is the pressure within the pleural space, which is the space between the lungs and the chest wall. Mechanical ventilation can also increase pleural pressure. High pleural pressure can compress the blood vessels in the lungs, reducing blood flow and oxygen delivery. This can lead to further lung injury and even heart problems. Two significant complications associated with mechanical ventilation are volutrauma and barotrauma. Both are caused by excessive pressure in the lungs and can lead to serious consequences. Volutrauma occurs when the lungs are overinflated with too much air volume. This can happen when the tidal volume, the amount of air delivered with each breath, is set too high on the ventilator. Excessive tidal volumes can stretch and damage the alveoli, leading to inflammation and leakage of fluid into the air spaces. This fluid buildup can impair gas exchange and worsen lung function. Barotrauma results from high pressure in the lungs, often caused by high airway pressures during mechanical ventilation. This can occur due to factors such as reduced lung compliance, airway resistance, or rapid inspiratory flow rates. High pressures can rupture the lung tissue, leading to air leakage into the chest cavity, known as pneumothorax, the space around the heart, known as pneumomediastinum, or even into the bloodstream, known as air embolism. The settings on a mechanical ventilator must be carefully chosen to provide adequate ventilation while minimizing the risk of VILI. Tidal volume, respiratory rate, and inspiratory flow are crucial settings that influence lung pressures and the risk of lung injury. High tidal volumes, as mentioned earlier, can cause volutrauma. Studies have shown that using lower tidal volumes, typically 6 milliliters per kilogram of predicted body weight, can significantly reduce VILI and improve outcomes in ARDS patients. This approach is called lung protective ventilation. Respiratory rate also plays a role in lung protection. A high respiratory rate can lead to air trapping and increased airway pressures, especially in patients with obstructive lung diseases. Adjusting the respiratory rate to maintain a normal arterial carbon dioxide level while minimizing airway pressures is essential. Inspiratory flow, the speed at which air is delivered during inhalation, can also impact lung pressures. High inspiratory flows can generate high peak pressures within the airways, potentially contributing to barotrauma. Lower inspiratory flows may be preferable to reduce peak pressures and minimize lung injury. However, simply setting these parameters to low values is not the solution. Each patient with ARDS has different reasons for needing mechanical ventilation. The best settings for one patient may be harmful to another.